You know, arrhythmia is one of the most common subject in cardiology, and usually the burden of arrhythmia nowadays is increasing because of aging population and also presence of several comorbidities like hypertension, diabetes, and coronary artery disease. Uh, And palpitation and arrhythmia, you know, very annoying symptoms, and it is very distressing for the patient. But frequently, the patient may be asymptomatic until present with complications like stroke or sometimes sudden cardiac death. And 1 in 4 adults over the age of 40 will develop some source of arrhythmia. And in general, the arrhythmia accounts for 10 to 15% of sudden cardiac death. Regarding the arrhythmia, it could be tachyarrhythmia or could be bradyarrhythmia. Today we concentrate on the tachyarrhythmia. The tachyarrhythmia could be regular, could be irregular, could be wide, could be narrow. Each one of them has several differential diagnoses, and we have to deal with them separately. And I tried to highlight on the most common arrhythmias for today. In order to understand the mechanism of arrhythmia, we have to know something about the action potential of the myocardial cells. We have 5 phases of the action potential. The phase 0 is the rapid upstroke of the sodium channels and what we call depolarization phase, and followed by repolarization phase, which involves 3 phases. Phase 1 is caused by transient outflow of the potassium channels, and plateau phase, which is caused by calcium and sodium channel influx. And phase 3, it is a repolarization phase caused by outflow of the potassium channel. And then we have phase 4, which is a resting state. Usually we have 2 intervals. We have absolute refractory period or effective refractory period, which is here, and it cannot receive any signals in this period. So it is very stable interval, followed by relative refractory period. It is unstable. So any strong stimulus or trigger, it will induce depolarization and induce arrhythmia. And if we translate this to the ECG, the beginning of the QRS up to mid portion of the T wave is effective refractory period, and the remainder of the T wave is the relative refractory period. Sometimes we may see PVCs with R wave, which is located over the T wave, what we call R on T phenomena. This is a very serious, because sometimes it will induce arrhythmia because it's located on the relative refractory period, and it will receive and initiate depolarization. Regarding the mechanism of arrhythmia, we have 3 mechanisms for arrhythmia. Could be the defect in the impulse formation, like increased automaticity or abnormal automaticity. Some myocardial cells will autonomously firing the signals, regardless of the SI node or IV node, and it may cause tachycardia. Or the second mechanism is triggered activity, which is, as I mentioned, is related to after depolarization. If the signal is strong and located on the phase, late phase 3 or phase 4 of the action potential, it will induce repolarization at tachycardia. And what we call this is early after depolarization. And we have late after depolarization if the signal in the phase 4 of the action potential induce arrhythmia. This mechanism responsible for many types of arrhythmia, especially electrolyte disturbance, and the most important is torsa-dipoa VT, which is a polymorphic VT caused by long QT interval. And we have reentry. This is the most common mechanism of arrhythmia. In re-entry, we have two pathways. We have two pathways. One is long refractory period, one is short refractory period, and with different conduction properties. When the signal comes here, it blocked in this pathway, and it will transmit in this slow pathway. And when reach the end of the pathway, the refractory period of this pathway will recover, and it will receive the signal, and it causes re-entry. So this is a very common. Usually whenever you have a scar tissue and normal tissue or slow or fast pathway, this is responsible for the mechanism. And now let us see how beta blockers affect these three mechanisms. Usually regarding the re-entry, beta blockers slows the IV node. When the IV node is slowed, so it breaks the circuit here. Regarding the triggered activity, which is a key role, beta blocker, because it will prolong the refractory period. So make this stimulus, this trigger, instead of locating it to the relative refractory period, it will locate on the effective refractory period and will not receive it by the tissue. And regarding the automaticity, beta blocker directly lowers the sinus node and decrease ectopic pacemaker activity. Let me share with you some examples or cases to understand the role of beta blocker. This is a 16 years old patient presented with recurrent palpitation with positive family history of sudden cardiac death. And this is the ECG finding of the patient. Usually the ECG, you can appreciate there is wide complex tachycardia, and I cannot see any P wave here. And the tachycardia is right bundle branch block morphology. So our differential diagnosis usually could be VT or SVT with aberrancy or SVT with pre-excitation, as I say, antidromic IVRT. But there are certain features in favor of VT because there is a right bundle branch block morphology, but it is very atypical. It is monomorphic R in V1 and deep S in V5, V6, which is unusual for typical right bundle branch. And also there is QS in inferior leads that is also against supraventricular tachycardia. So the diagnosis of VT now is clear, and this is the echocardiography of the patient. You can appreciate there is a concentric LVH. There is a severe left ventricular hypertrophy, and there is LVOT obstruction. So there is hypertrophic obstructive cardiomyopathy. One may ask why hypertrophic cardiomyopathy causes arrhythmia. There are several mechanisms like myocardial disarray and fibrosis. It causes scar tissue, and scar is a substrate for re-entry tachycardia. And also it will cause microvascular ischemia, which is a substrate for after depolarization abnormality. And again, LVOT obstruction, it will induce triggered activity. And of course, left atrial dilatation cause re-entry AF. And finally, sympathetic overdrive will induce excitability. And the beta blocker is the mainstay of the treatment for hypertrophic cardiomyopathy with or without obstruction, because it decreases the heart rate. And whenever the heart rate decreased, usually the LVOT will decrease and the anginal symptom decrease, and also the exercise tolerance become better. That's why in the guideline, this is from ESC guideline, the beta blocker is class 1 indication for hypertrophic obstructive cardiomyopathy, especially if you have obstruction. and usually non-vasodilating beta blockers, like metoprolol or bisoprolol is preferred. The next patient is a 50 years old patient presented with shortness of breath and palpitation. The patient was hypertensive and diabetes. Coronary angio before 1 year was normal. And this is the ECG finding of the patient. You can see here there is sinus rhythm, but there is frequent premature ventricular contraction in the bigeminal form. That's why when you have frequent PVC, usually it is associated with some sort of LV dysfunction. This is the echo of the patient. The movie. Oh. When we have a patient with a LV dysfunction and frequent PVC, usually we have to think about PVC-induced cardiomyopathy. But sometimes also LV dysfunction can cause frequent PVC. So it is like an egg and chicken story. We cannot estimate which one is a trigger for the others, but we have to do something to understand whether it is due to PVC-induced or not. Usually the first step, we have to control the PVC and then reassess the LV function. Sometimes cardiac MRI will help us. And the number of the PVC burden is associated with LV dysfunction. The higher the burden, the more likely the patient will develop LV dysfunction. We have to suppress the PVCs by changing lifestyle. And again, the beta blocker is initial drug. Should start at the beginning of any patient with PVC and then reassess. If not responded, then we add antiarrhythmic drugs. And of course, catheter ablation is curative in 80 to 85% of patients. And nowadays, catheter ablation is upgraded for certain types of PVC, especially from the RVOT origin or fascicular origin. Even you can start before antiarrhythmic drugs. So the beta blocker is class 1 or class 2A for most types of the PVC. The last patient is a 60 years old female patient associated with episodes of palpitation and dizziness. And this is the ECG of the patient. You can see here there is no clear P and there is irregular interval. So it's a classical ECG finding of AF. In AF, there is the upper and lower chambers are not coordinated and causing irregular heartbeat. And this is the echo finding of the patient. You can see there is dilated left atrium. It means there is a long-standing process. We have different types of AF. I'm sure all of you know the types. We have first diagnosed paroxysmal AF when it's less than 7 days, persistent AF when more than 7 days, long-standing when more than 12 months, and permanent AF when the patient and the doctor accepted that there is no rule of rhythm control. And AFib is one of the major factors for comorbidity and mortality. It increased 5 times risk of ischemic stroke, and also it increased the heart failure, especially HFpEF, and also associated with recurrent hospitalization. And in the guideline, we have AF care pathway. If we apply this pathway for all patients with AFib, I'm sure we can deal with the patient properly. The C is the comorbidities. So we have to deal with the comorbidities at the beginning, because if we not deal with the comorbidities, the patient will not stay for a long time in sinus rhythm. That's why we have to control the blood pressure, If the patient has heart failure, we have to do optimal medical treatment. Weight loss is important. Managing obstructive sleep apnea. And the A letter is the anticoagulant. Every patient should have Chad's-VAS score to know whether there is a risk for stroke or not. And please do not give antiplatelet instead of anticoagulant for AF patient, because it has no any rule for prevention, and it is class 3 in the guideline. And R is the rate and rhythm control, which is an important part of the AF management. And usually every patient with AF should have rate limiting medication as a background therapy in all AFib patients, or sometimes first choice therapy for patient with minor symptom, or if the patient has a failure of rhythm control. And regarding the rate control, usually according to the guideline, the heart rate less than 110 is accepted in most of the patient, unless the patient has LV dysfunction or persistent symptoms after rate control, or the patient has CRT, that the elevated heart rate interfere with the function. In such a condition, the strict heart rate control should be performed, which is less than 80. And regarding the heart rate control, it is better to initiate beta blockers as soon as possible. According to the guideline, is a class 1 indication regardless of the ejection fraction, whether it is more than 40 or less than 40. And initiation of the rate control is important to prevent further progression to persistent AF. And regardless of the pattern of AF, beta blocker is still class 1 in all types, in paroxysmal, in persistent, and in permanent AF. So beta blocker is an essential drug. And E is the evaluation. We have to evaluate patient every 6 months for rate control, for any comorbidities, for any new symptoms. Thank you.